Hanji everyone, very good evening to everybody. Good evening. Good evening. So are we all ready for the session today? Yes. All right. So I hope that we had, utilized the yesterday's session. Yes. Right. Okay. PDF, I have already shared Kalwali PDF in my Telegram channel. So you can please take it from the Telegram channel. I have also shared it in the DAMS FMGE Telegram channel as well as my personal channel. Okay, so we can all take the PDF from there, the annotated PDF. I will upload for today's class as well. So now tell me, how was the test for everyone? Did you all give the obstetrics test paper? Yes. Okay, so we have tried to cover the important things और कल जैसे कोशिश करेंगे कि आज का भी discussion high yielding हो, right? But everyone, so you must the test is free for everyone, so you can go onto the eMedicoz app homepage daily quiz section and wahan se you can attempt the test, right? All previous predictor series tests are also available there itself, so you can attempt the other tests as well, and the discussions, as you all know, are available on the YouTube channel. Chalo, so aaj ka shuruaat kare. Yes. Okay, perfect. Are you ready for first question of the day? Chalo. So I think the first question is not very difficult, but it is an important MCQ. So let's look at the first question. It says, all are indications for surgical treatment of ectopic except, right? So can you tell me what is the answer? Although you can see the little answer there. What is the answer? Yes. So it has to be sac size 3 centimeter, cardiac activity absent, है ना? Can you tell me what is wrong with option B? Why option B is not the answer? Because यहाँ पे लिखा है cardiac activity present, है ना? So when cardiac activity is present, I have told you what is the preferred management. Then the preferred management is surgical, है ना? What is, whenever the family is complete, again the preferred management is surgical. Yes. फिर क्वेश्चन अगला ऑप्शन नंबर 4 देखो, राइट? क्वेश्चन नंबर ऑप्शन नंबर 4 says that rising trend on day 7 after methotrexate. Do you remember this? Medical management पे day 1 पे we have given injection methotrexate, and on day 4 and day 7 we are sending serum levels of HCG. Yes, so if you see a rising trend on day 7, it means it is a failed medical management. So if you see rising HCG, it is failed medical, right? So again, which means you have to go for surgical. Can you tell me what are the other indications for surgical management? So other indications for surgical management बहुत important है बच्चे. If they are saying patient is hemodynamically unstable, है ना? Second, the next indication, if it is a ruptured ectopic, ठीक है? So ruptured ectopic में भी we will always answer surgical management. Third, criteria for medical management not met, right? Criteria for medical management not met. And इसीलिए, can you tell me what was the criteria for sac size to say that you will do surgical? Any time the sac size is bigger than 4 centimeters, we are going to do a surgical management. ठीक है? Then please remember, anytime we are saying HCG value is more than 5,000 international units, again we are going to say that we are going to do a surgical management, right? So ये दोनों चीजें याद रखोगे, cardiac activity present तो surgical management, है ना? Okay, then as I said, other than that, cardiac activity present is an indication for surgical management, family complete is an indication for surgical management, and failed medical management is also an indication for surgical. Shabash, very good job done. Now I want to ask you two other important questions. Pehla सवाल, can you tell me if it is ruptured ectopic, what surgery are you going to do, beta? Ruptured ectopic अगर लिखा होगा, which means they could talk about unstable vitals, they can talk about abdominal tenderness, लेकिन the important word here is rebound tenderness. Rebound tenderness ho, then there is guarding, rigidity. Yes, these are all words to tell you that we are dealing with ruptured ectopic. तो अगर ruptured ectopic है, can you tell me what surgery you will do? Very good. Never answer salpingostomy. Salpingostomy is incorrect. शाबाश. हमेशा क्या आंसर करेंगे? Salpingectomy. Right? So for ruptured ectopic, it has to be salpingectomy. Very good. Now I want to ask you, family complete अगर होगा तो क्या करोगे? If it is an ectopic pregnancy and family is complete, so we said surgical, but again, what surgical? Again, the answer will be salpingectomy, not ostomy. So in both these conditions, we will do a jectomy. Very good. Now you have to tell me some important one-liners. Yes? मुझे बताओ, what is the most common risk factor for ectopic pregnancy? Most common risk factor for ectopic? The answer is pelvic inflammatory disease, है ना? And if we ask you what carries highest risk, तो उसमें आपने आंसर करना है any kind of tubal surgery, right? So any kind of tubal surgery या फिर previous ectopic, they are very good answers for highest risk. चलो एक और one liner बताओ, which is the most common site for ectopic? Most common site for ectopic? Yes, it is going to be ampulla. ठीक है, it is going to be ampulla. Or which ectopic will rupture late? Which ectopic ruptures late? So जब ruptures late होता है तो उसका आंसर है interstitial, which is the other name intramural, है ना? This will rupture at around 10 to 12 weeks. Shabash. So these are some of the important PYQs also and important one-liners also when it comes to ectopic pregnancy. ठीक है बच्चे? Shabash. Nice. Very good. Okay. And so these are other things that I want to ask you is, वो हमने कल वैसे बात किया था. Can you tell me which is the narrowest part of the fallopian tube? So remember, when we talk about narrowest part of the fallopian tube, then it is interstitial. Ampulla बच्चे remember करना, it is the widest part. Isthmus भी narrow होता है. Isthmus किस चीज का site था? It is the site for tubal ligation, है ना? It is the most common site for tubal ligation. Right? So these are other things that you should know and we keep on asking you. So you should know medical management कहाँ करना है और surgical कहाँ करना है. अच्छा मुझे बताओ, overall what is the preferred management? Is it medical or is it surgical? So overall preferred होता है medical management, मगर उसमें हमेशा you have to see whether the criteria are met or not met. चलो last question देखते हैं and then we will move forward. Can you tell me what are the named criteria for ovarian ectopic? कौन बताएगा? Named criteria for ovarian ectopic. So ovarian ectopic में आपने याद रखना है, the named criteria are Spiegelberg criteria. Okay, they are Spiegelberg. Abdominal वाला, abdominal ectopic का named criteria, anybody? So for abdominal ectopic, the named criteria are Studiford. Shabash. Very nice. Good job done, people. And what about cervical ectopic बच्चे? Cervical ectopic के criteria है या तो Palman या फिर Rubin's criteria. They are both for cervical ectopic. Okay, excellent. Good job done. Are we all good to go for the second question? Yes? Everyone ready for the second question? Chalo. Let's see so that then we can discuss. So next question है, in which of the following, है ना? Good evening everyone. Welcome, welcome. आ जाओ so that we can make it most high yielding and we will discuss important points, है ना? चलो. Which of the following anti-D is given? So ये बहुत important है, confuse नहीं होना, basic concepts हैं. whenever the ICT या DCT is positive, इसका मतलब क्या होता है? इसका मतलब है sensitization has happened. So once sensitization has happened, do you want to give anti-D? No. So anti-D is not given. Now look at option number D. Option number D देखो, husband blood group is negative. इसका मतलब mother भी negative है और husband भी negative है, so the baby cannot be positive. So again, there is no risk of isoimmunization and इसीलिए no anti-D. But look at option number C, है ना? Option क्या है? Option C is the answer here. So let's look at option C. Option C कह रहा है fetus is Rh positive. So yes, when the fetus or the baby, right? So जब तक वो in utero है, we are saying fetus blood group. जब बाहर आएगा तो then we will talk about baby blood group, है ना? So please remember, when this is positive, then there is risk of sensitization, है ना? So now there is risk of sensitization. So should I give anti-D or not? Yes, but कब देंगे? Provided ICT is negative. ठीक है बच्चे? So positive, there is risk of sensitization. So if ICT या DCT is negative, then we will give anti-D. ठीक है, सबको समझ में आ गया? Yes. So इसमें भी हम तब देते हैं जब ICT before delivery और DCT after delivery negative हो. Clear? जल्दी से thumbs up दे दो everybody. Okay. Now the next important thing that I want you to know is, can you tell me anti-D का ideal या best time क्या होगा? ICT बेटा है इनडायरेक्ट कूम्स टेस्ट और DCT है डायरेक्ट कूम्स टेस्ट. DCT करते हैं आफ्टर डिलीवरी, ICT करते हैं इंट्रा यूट्राइन जब होता है, बेबी फीटस होता है. ठीक है. सो व्हाट इज द बेस्ट टाइम? नो, सो बेस्ट टाइम टू गिव anti-D is 28 weeks बेटा. ओके, 28 weeks. एंड व्हाट डोज डू वी गिव हियर? जल्दी बताओ. यस, 300 micrograms. Very good. We will give 300 micrograms. It is a intramuscular injection. Yes. So best time is 28 weeks. अच्छा, इसके अलावा please remember, if there is a spontaneous abortion or a MTP before 12 weeks, is there any need for anti-D? Then the new guidelines say, WHO की guidelines कहती हैं, then there is no need to give anti-D. Although India में हम देते हैं, मगर WHO guidelines say there is no need if there is a spontaneous abortion or MTP before 12 weeks. Yes, but any time you want to give it before 12 weeks, what is the dose? Before 12 weeks, the minimum dose requirement is 50 micrograms. ठीक है, so the minimum dose required before 12 weeks is 50 micrograms. And beyond 12 weeks, the dose is going to be 300 micrograms. ठीक है बच्चे? Now, can you tell me कि amniocentesis में, if we are doing an amniocentesis, what dose of anti-D are you going to give? So, amniocentesis में, the dose of anti-D will be 300 micrograms. Yes? So why? Because it is done beyond 12 weeks. What about chorionic villus sampling? Now this is a little controversial. Chorionic villus sampling can be done as early as 10 weeks, है ना? So if we are doing it before 12 weeks, then various guidelines say any dose between 50 to 150 micrograms can be given. ठीक है. So various guidelines हैं, वो कहते हैं any dose, minimum 50 तो देना ही देना है. There are certain guidelines which say you give up to 150 micrograms. So 50 to 150 micrograms can be given, but beyond 12 weeks यहाँ पे भी आंसर क्या रहेगा? 300 micrograms, right? So यहाँ पे भी आंसर क्या रहेगा? 300 micrograms. ठीक है बच्चा? Is that clear to everybody? Okay, very good. Now can you tell me what dose will you give after delivery? After delivery, again, it has to be a full dose. ठीक है? 300 micrograms intramuscular within 72 hours. Again, I am repeating my question. मगर मुझे बताओ, यहाँ पे when will you give it after delivery? If baby blood group is what? The baby blood group has to be RH positive, है ना? And DCT कैसा होना चाहिए? DCT should be negative. ठीक है? The direct Coombs test should be negative and the baby's blood group should be RH positive. ठीक है everyone? Good to go? Now I want to ask you, what value of ICT? When you say ICT is positive, इसका मतलब है she is sensitized. Yes? Can you tell me what is the critical value of ICT? The critical value is more than or equal to 1:16. So now you have to tell me, if the value is more than or equal to 1:16, जैसे कि 1:32, 1:64, right? So anything more than 1:16, if I ask you what is next step, आप क्या आंसर करोगे? Yes, very good. But what will you answer? The answer has to be MCA Doppler, because we have to look for fetal anemia, है ना? So we will do a MCA Doppler. Yes, क्या study करते हैं बेटा जी इसमें? PSV. Yes, very good, excellent. Peak systolic velocity. Can you tell me what value of PSV is critical value? So yes, PSV cut off होता है 1.5. Yes, cut off क्या है? 1.5 MOM, multiples of median, right? Which will indicate fetal anemia है या नहीं है. Now tell me, if critical value of ICT, yeah, ICT value is less than 1:16, then what is the next step? Who is going to tell me? Then the next step will be repeat titer after 4 weeks. Yes, then we will repeat titer after 4 weeks. Shabash, very good. Now the last part of the algorithm. Agar PSV is more than 1.5, what are you going to do? It will depend on POG. Agar POG 34 से ज़्यादा है, we will do a delivery. ठीक है, ध्यान से सुनो everybody. If peak systolic velocity is more than 35 and POG is more than 34 weeks, you will deliver the baby. If the POG is less than 34 weeks, then can you tell me what will you do next? Yes, then the answer is chordocentesis. Right? Then the answer is chordocentesis. Shabash, very good. And if PSV is less than 1.5, तो क्या करोगे बताओ? Then we are going to do repeat MCA Doppler after 2 weeks. ठीक है? So everyone clear? Are you clear with all the possible clinical questions? Everyone? Yes. So let me know you're good to go. चलो, so this is important बेटा जी, ये आपके एग्जाम में बार बार RH नेगेटिव पे क्वेश्चंस आ रहे हैं, so we are going to ensure that we don't do them wrong. Also please remember, हमने एक छोटा सा वन लाइनर है मगर हमने किया हुआ है क्लास में, ये जो 300 माइक्रोग्राम्स है, remember this will neutralize around 30 ml of fetal blood and how many fetal RBCs? 15 ml. Okay, so this will neutralize 30 ml of fetal blood and 15 ml of fetal RBC, right? Agar the hemorrhage is up to 30 ml, we have to give a dose of 300 micrograms, right? Up to 30 ml, we have to give 300 micrograms. उससे ज़्यादा होगा तो कौन सा टेस्ट करते हैं? Clay-Hor-Betke test. Yes. So if hemorrhage is more than 30 ml, then you will do Clay-Hor-Betke test. So if feto-maternal hemorrhage more than 30, then do a KB test. Yes, very good Shubham, good job, very well done. Chalo, आगे बढ़े. Now let's look at the next question. Your next question is, your patient presents with a hemoglobin of 6.5 at 36 weeks. What is the management? So, what type of anemia your patient has? Severe anemia. Yes. So, anything less than 7 gram% is considered as severe anemia. Yes. So, less than 7 gram% is severe anemia. Yes. अगर severe anemia हो तो हमें क्या देखना है? How much is the hemoglobin? If hemoglobin is less than 5 at any POG, management क्या होता है? Blood transfusion. Yes, then we will do blood transfusion. और अगर hemoglobin is between 5 and 6.9, तो क्या करना है? Then you have to do the or look at the period of gestation. Yes, अगर POG more than 34 है, then you will give blood transfusion. Yes, whereas if it is less than 34, then we will give injectable iron. कौन सा iron देते हैं? Iron sucrose, right? So here we are going to give iron sucrose, which is given as a IV infusion, not IM beta G. Okay, then we will give IV infusion. Very good. Now also please remember, anemia में जब हम blood transfusion देते हैं, do we give whole blood or packed cells? Yes, so we have to give packed cells. So we call it as PCV, packed cells. Okay, not whole blood. So this is with respect to severe anemia. ठीक है? Now, अगर आपके patient को moderate anemia हो, so anywhere which is between mild to moderate anemia, what are we going to do? Less than 34 weeks, we will give oral iron. And if she is more than 34 weeks, then what are we going to do? Injectable. Yes, so then we will give injectable iron. Oral iron में how many tablets are you going to give? IFA tabs. कितनी देनी है? So then you have to give 2 tablets per day. Please remember, this is different from prophylaxis, है ना? Prophylaxis में कितना देते हैं? 1 tab. यहाँ पे you have to give 2 tabs per day. ठीक? Okay. Please remember, if your patient has signs and symptoms of heart failure, right? For example, edema है, breathlessness है, cough है, right? So if she has signs and symptoms of heart failure, any POG, any hemoglobin, what is the management? It is going to be blood transfusion, right? So because anemia has caused heart failure, if she has signs and symptoms of heart failure, then the management will be blood transfusion. Again, I'm saying blood transfusion, magar it is going to be a packed cell volume. Okay, I want to ask you, your patient has a hemoglobin of 8 gram% at 8 weeks. What do you want to do? Do you want to wait? Do you want to give her hemoglobin iron, or you want to give her injectable or blood transfusion? क्या करना है? जल्दी बताओ. So this patient has moderate anemia, है ना? This patient has moderate anemia. So anything less than 10 is moderate anemia, है ना? So मुझे बताओ, what are you going to do? We will give her oral iron, right? So give her oral iron. Yes, 2 tabs per day. So you have to treat. Please remember, injectable iron is contraindicated in the first trimester. First trimester में बेटा injectable mark नहीं करना है. You are going to mark what? Oral iron. अगर साइंस ऑफ हार्ट फेलियर होंगे देन यू विल मार्क व्हाट, ब्लड ट्रांसफ्यूजन. ठीक है, एवरीबडी क्लियर? ओके, वेरी गुड. Always remember, whenever we are talking about anemia, the most common anemia in pregnancy is IDA. What kind of anemia do you see? So अगर ऑप्शन में IDA नहीं होगा then you have to go and mark microcytic hypochromic. Okay, microcytic hypochromic. Very good, excellent. Now you have to tell me these things. I am sure ये आपने PSM में भी किया है. अनीमिया मुक्त भारत अभियान. Yes. When do you start iron folic acid prophylaxis? कब शुरू करना है? So prophylaxis will be started after 12 weeks, right? And you will give 1 tab IFA per day. I want to know from you how many days. So you will give it for 180 days or 6 months during pregnancy, and you will give another 180 days after delivery. Perfect, everybody knows this, so good job done. Can you also now tell me, when we are talking about IFA tab, इसमें कितना iron है और कितना folic acid है? Very good, 60 milligrams of iron and 0.5 milligrams of folic acid. Yes, 0.5 milligrams of folic acid. Very good. Good job. Good job. Perfect. And now albendazole बता दो कब देना है, because as far as anemia मुक्त भारत is concerned, we are also supposed to do deworming, है ना? So deworming के लिए what is the drug of choice? Tab albendazole. डोज 400 मिलीग्राम्स है ना, और कितना देना है? सिंगल डोज. और कब देना है? सेकेंड ट्राइमेस्टर. डू नॉट गिव इट इन द फर्स्ट ट्राइमेस्टर, राइट? सो टैब एल्बेंडाजोल 400 मिलीग्राम सिंगल डोज इन द सेकेंड ट्राइमेस्टर. ठीक है, वेरी गुड, गुड जॉब. सो आर यू गुड टू गो विद द नेक्स्ट क्वेश्चन? यस, एवरीवन रेडी फॉर द नेक्स्ट वन? ओके, कैन यू टेल मी what was the dose of folic acid that you gave in previous history of neural tube defects? What is the dose of folic acid that you gave in previous history? So now this has to be high dose of 4 milligrams per day, है ना? High dose of कितना? 4 milligram per day. And this is given up to 12 weeks. उसके बाद you will give her iron folic acid tablets. Very good. And remember the other place जिसमें आप high dose देते हो वो है a woman with anti-epileptics. Yes, so a woman with anti-epileptics. Again, you give it up to 12 weeks. Yes. What is the dose that you give for prophylaxis? अब please confuse नहीं होना है. As far as the requirement is concerned, the requirement is only 0.4 milligrams. Yes, in the according to the Indian guidelines, हम लोग जो टैबलेट देते हैं हमारे यहाँ टैबलेट 0.4 की नहीं है. So in India, the only tab that is available is 0.5. So we are giving 0.5. Yes, but the requirement is how much? 0.4. ठीक है, 0.4 is the minimum requirement. ठीक है, is that clear to everyone? Yes. Sickle cell anemia में बेटा फर्क ये है, you are going to give approximately 5 milligrams per day and you are giving it throughout pregnancy, not up to 12 weeks. ठीक है, we are giving it throughout pregnancy. Is this clear to everyone? Okay. And lastly, if your patient has folic acid deficiency, फिर कितना डोज है? 1 milligram per day, right? So then we will give 1 milligram per day till the time we correct the deficiency. ठीक है बच्चा? Is this clear to everyone? So don't get confused. Good job. Everyone ready for the next slot? Let's look at the next question now. So uterus becomes a pelvic organ by which time in the postpartum phase? What is the answer? मैंने एक रूल बताया था, जब भी एग्जाम में ये पोस्टपार्टम वाले आंसर ना आते हो, अ सेफ बेट इज 2 weeks. Yes, so it becomes a pelvic organ by 2 weeks. कार्डियक आउटपुट कब वापस आती है? नॉर्मल. कार्डियक आउटपुट ऑल्सो बिकम्स नॉर्मल बाय 2 weeks. Okay, so what else was by 2 weeks? Postpartum blues. याद है आपको? Postpartum blues वो कब तक रहते हैं? Up to 2 weeks. Beyond 2 it becomes postpartum depression, है ना? So postpartum blues का भी आंसर क्या है? 2 weeks. Okay, now let's talk a little thing about this. Can you tell me when we talk about the uterus ka involution, where does it lie on the second day postpartum? So remember, first 24 hours no change in position, right? And after 24 hours by 1 centimeter ya 1 finger breadth per day. So after 24 hours it is 1 finger breadth per day, which means on second day, okay, on second day postpartum it will lie 1 finger breadth below umbilicus, okay, 1 finger breadth below umbilicus. Very good. HCG also returns to normal by 2 weeks. ठीक है, उसका भी आंसर 2 weeks है. So as I said, जनरल आंसर के लिए अगर आपको पोस्टपार्टम याद नहीं रहे तो रिमेंबर द जनरल रूल एज 2 weeks. ठीक है. नाउ very important, when we talk about involution of uterus, where is the uterus after delivery? So immediately after delivery uterus कहाँ होता है? It is just below umbilicus, right? Which means corresponds to what level? The lower border of umbilicus corresponds to 20 weeks, right? So 20 weeks, just below umbilicus or 20 weeks. 1 week पे कहाँ होता है बेटा? 1 week पे remember it is 1 week postpartum. The uterus is midway between umbilicus and symphysis pubis. 2 weeks पे it becomes a pelvic organ and 6 weeks पे complete involution. Very good. So good job, very well done. एक और चीज मैंने क्लास में बताया था कि इसको हम लिखते 2 weeks हैं मगर कभी कभी वो डेज में पूछ लेते हैं. So when does uterus become a pelvic organ? उसका आंसर क्या बताया था? अगर डेज में पूछेंगे तो 10 to 12 days, right? So 2 weeks is the general answer, or we can remember it as 10 to 12 days. चलो, very important, बताओ weight of uterus immediately after delivery. कौन बताएगा weight of uterus immediately after delivery? Yes, 1000 grams. ठीक है, और 6 weeks पे कितना होता है? About 80 grams. So complete involution पे it is about 80 grams. Okay, next question, सारे आंसर करोगे. What is the shape of external os after delivery? It becomes a transverse slit. And will it ever become circular again? No, it will never go back now. अब वो दोबारा कभी circular नहीं होगा. It will always be a transverse slit. ठीक है? Perfect. Very good. Next question. Who is going to tell me the order of lochia? The correct order of lochia? Rubra, serosa and alba. Right? So rubra, serosa and alba. So first 3 days, 4th to 9th day, and beyond 10 days it is alba. Now quickly tell me, what is the average duration of lochia? Average duration में आपने मार्क करना है 4 weeks. मगर अगर पूछें up till what time is it normal? So can be normal up to 6 weeks. right? So can be normal up to 6 weeks. Everyone clear? Also, please remember, when we talk about purpureal pyrexia, yes, can you tell me, do we exclude the first 24 hours or do we include the first 24 hours? So this has to be fever more than 38 degrees centigrade, but on 2 days, right? But this has to be from day 2 to day 10. You have to exclude first 24 hours. पहले 24 hours में अगर fever आता है, it is not taken as purpureal pyrexia. It is a reactionary fever. ठीक है? So you have to exclude the first 24 hours. Very good. बहुत अच्छे से पढ़ाई करके आए हो भाई. Very nice. Good job. Then who is going to tell me, when we are talking about postpartum, when should breastfeeding begin? When should breastfeeding begin? So remember, it is not immediate. What is the answer? Within 1 hour, right? Breastfeeding should begin within 1 hour. Also, can you tell me what is the reason for after pains? After pains? Yes. So every time the baby suckles, there is release of oxytocin. There is release of oxytocin, which will cause uterine contractions. And that is the reason for the pain. Very good. कौन बताएगा what is a best answer for contraindication of breastfeeding? Best answer क्या होता है? सबसे अच्छा आंसर है गैलेक्टोसीमिया. ठीक है, गैलेक्टोसीमिया. इसके अलावा एक्टिव untreated pulmonary tuberculosis, right? Active as well as untreated. फिर herpes lesions on the breast. Yes, so herpetic lesions on breast. So active lesions on breast. Then women on chemotherapy, women on radiotherapy, right? So these are some of the important questions. जल्दी से मुझे बताओ order क्या होता है? So सबसे पहले, when we talk about order of breastfeeding, what is the first thing that will happen? पहला है mammogenesis. Yes. What is this followed by? Lactogenesis. Then galactokinesis. And followed by galactopoiesis. Right? So this is the sequence. ठीक है बच्चा? Is this clear to everybody? So yes, so these are some of the important questions. No, HIV is not a contraindication beta ji. HIV में Indian guidelines and NACO say breastfeeding is recommended. ठीक है? So breastfeeding is recommended. It is not contraindicated. All right? Okay. Quickly a few more postpartum questions and then we go to the next one. Can you tell me postpartum tubal ligation कब तक करते हैं? Postpartum tubal ligation, it can be done up to 7 days. Postpartum IUD कब तक डाल सकते हैं? Up to 48 hours. Okay. When should you begin contraception in non-breastfeeding? So in non-breastfeeding, contraception will begin at 3 weeks and in breastfeeding, begin at 3 months. Okay, then you will begin at 3 months. Okay, which is the contraception of choice in lactating women? So remember, in lactating women, contraception of choice is progesterone only pills, जिनका नाम है mini pills, and IUDs can also be given. कौन सा नहीं देना? In lactating women, do not give OCPs, especially up to 6 months. उसके बाद आप दे सकते हो because you are anyways now she is going to start top feed. Is this clear to everybody? चलो, good to go everyone. So we will go on to the next question now. Your patient is on examination found to have infraumbilical flattening. The fetal heart sounds are heard over the lateral side. What is the presentation? Batao, what is the answer? These are easy questions. I'm sure so many of you would have got 20 out of 20 today. Huh? Yes. So the answer is occipitoposterior. Right? So the answer is occipitoposterior. Now, I want you to know this. Look at this image, and these are important things. Pehli cheez, there is infraumbilical flattening. Then, can you tell me where is the back? The back is towards flanks. Isiliye, where will be fetal heart rate? Fetal heart rate is also in the flanks. Limbs kahan hai? Limbs are near midline. And anterior shoulder away from midline. Okay. Can you tell me PV examination par which fontanelle will you feel? If it is occipitoposterior, then it is possible that the head is deflexed. So agar deflexed hoga, kaun sa fontanelle feel hoga? Anterior fontanelle, which is rhomboid in shape, hai na? Then we will feel the anterior fontanelle. Perfect. Very good. Can you tell me engaging diameter क्या होता है when the head is deflexed? ये बहुत important questions है बेटा. So if the head is deflexed, what will be the engaging diameter? सबसे अच्छा आंसर है occipitofrontal. Okay, occipitofrontal. अगर वो ऑप्शन में नहीं होगा, then you will go with suboccipitofrontal. ठीक है, so then we will go with suboccipitofrontal. ठीक, everybody clear? Occipitofrontal is 11 centimeters. Okay, sometimes we say even 11.5 centimeters. So 11 to 11.5 is what is occipitofrontal. Suboccipitofrontal होता है 10.5. ठीक है, is that clear? चलो, very good. Now, when in relation to OP, we are always asking you the types of pelvis. So, ये labeled है. Please remember, this is on the basis of shape of inlet, right? So, what is the shape in a gynecoid pelvis? It is almost round. Android में कैसा है? Heart shaped. Yes. Anthropoid is anteroposteriorly oval. Yes, AP oval. Okay. And can you tell me transverse oval में क्या होता है? So if it is transverse oval, it is platypeloid. Now you have to tell me occipitoposterior कौन सी pelvis में मिलता है? OP. So when we ask you OP position, the most common is ROP and it will be seen in what? Android pelvis. ठीक है? So the answer will be android. Okay, very very important. Next, अगर मैंने पूछा persistent OP या direct OP, then can you tell me कौन सी pelvis होगी? So whenever we use a prefix, मैंने बताया था, the pelvis will change to anthropoid. Yes, anthropoid. Face to pubes किसमें मिलता है? Again, persistent OP में. Yes, so persistent OP में we get face to pubes. इसीलिए इसमें भी pelvis कौन सी होगी? Anthropoid. Yes, यहाँ पे भी the pelvis will be anthropoid. Very good, nicely done. Okay, now you will tell me deep transverse arrest कौन सी pelvis में मिलता है? The best answer is android followed by anthropoid. ठीक है, android followed by anthropoid. Okay, face presentation is different from face to pubes. ठीक है बेटा। सो फेस टू प्यूब्स और फेस अलग अलग है। फेस टू प्यूब्स का आंसर है एंथ्रोपॉइड, बट फेस प्रेजेंटेशन में कौन सी पेल्विस होती है? प्लैटीपिलॉइड, राइट। सो इसमें मिलती है प्लैटीपिलॉइड। इवन ब्राउ प्रेजेंटेशन इज सीन विद प्लैटीपिलॉइड, ठीक है। इज दिस क्लियर टू एवरीवन? सो दीज आर ऑल वेरी वेरी इंपॉर्टेंट, गड़बड़ नहीं करके आना है, यस। सो रिमेंबर दीज थिंग्स, दे आर इंपॉर्टेंट फॉर यू, ओके। सो ओपी में प्लीज रिमेंबर लेबर इज delayed, है ना। सो इट इज delayed and therefore अगर हम आपसे मैनेजमेंट पूछेंगे, what is going to be your answer? Wait and watch, right? So then your answer is going to be wait and watch. Now tell me, अगर deep transverse arrest है, what is the management? So majority of times DTA में the problem is the pelvis. So the single best answer is going to be cesarean section. So if it is a deep transverse arrest, the single best answer is going to be cesarean section. ठीक है। अरेस्ट ऑफ कौन सा स्टेज मिलेगा? अरेस्ट ऑफ एक्टिव फेज ऑफ लेबर, है ना। सो एक्टिव फेज ऑफ लेबर का अरेस्ट के लिए व्हाट आर द गाइडलाइंस? डू यू रिमेंबर? एक्टिव फेज अरेस्ट में हाउ मच शुड बी द डायलिटेशन? मोर देन और इक्वल टू 5 centimeters. Yes, more than or equal to 5 centimeters. And there should be no change in cervical dilatation for 4 hours with adequate contractions. ठीक है। मेम्ब्रेन्स कैसी होनी चाहिए? मेम्ब्रेन्स शुड बी रप्चर्ड। Fetal heart rate should be normal. Only then we will wait for 4 hours. अगर fetal heart rate normal नहीं है, then we will not wait for 4 hours. Then we will do a cesarean earlier. ठीक है? Is that clear to everybody? Very nice. Good job. Okay. What is the upper limit to wait for? अगर inadequate contractions हो तो आंसर होता है 6 hours, है ना। Then we can wait for 6 hours, but with good contractions we will wait for 4 hours. ठीक, चलो, good. Let's look at the next question. Simple सा question है physiological changes पे. So let's look at this. Your patient has increasing swelling in hands and legs, normal vital signs, clear lungs, no proteins in urine. So what is likely to be decreased in a healthy non-pregnant woman, मतलब compared to a non-pregnant woman, pregnancy में और क्या decrease होता है? बताओ। जरूर एग्जाम आपको बहुत हैप्पीनेस देके जाएगा, because you will do well in the exam. Yes, yes. Systemic vascular resistance decreases. जल्दी से बताओ, कार्डियक प्रीलोड को क्या होता है? इंक्रीज, बिकॉज प्लाज्मा वॉल्यूम इंक्रीज हो रहा है, तो प्रीलोड विल इंक्रीज. बट प्लीज रिमेंबर, आफ्टर लोड डिक्रीज होता है बिकॉज वैस्कुलर रेजिस्टेंस कम हो रहा है, राइट. कार्डियक आउटपुट इंक्रीज. ओके, बहुत कम चीजें हैं जो प्रेगनेंसी में डिक्रीज होती हैं. सो आज आप मुझे वो बताओगे कौन सी चीजें हैं जो प्रेगनेंसी में फिजियोलॉजिकली डिक्रीज हो रही हैं. कैन यू टेल मी? डिक्रीज इन प्रेगनेंसी. सो पहली चीज इज, एज वी सेड, सिस्टमिक वैस्कुलर रेजिस्टेंस. इसका मतलब even if we talk about blood pressure, it is going to decrease. ठीक है, ब्लड प्रेशर भी डिक्रीज होता है, डायस्टोलिक एज वेल एज सिस्टोलिक. ओके, व्हाट एल्स डिक्रीजेस इन प्रेगनेंसी? वेरी वेरी इंपॉर्टेंट व्हेन वी टॉक अबाउट डिक्रीज. और क्या डिक्रीज होता है? यस, रेजिडुअल एंड रिजर्व वॉल्यूम. शाबाश, वेरी गुड. और बताओ, कार्डियक आउटपुट तो इंक्रीज होती है बच्चे, डिक्रीज पूछ रहे हैं. हीमोग्लोबिन, excellent, because of hemodilution. है ना. सो हीमोग्लोबिन डिक्रीज होता है. अब मेरी बात ध्यान से सुनोगे, प्लेटलेट काउंट भी डिक्रीज होती है बट इट रिमेन्स इन द नॉर्मल रेंज. ठीक है. नाउ देयर कैन बी माइल्ड थ्रोम्बोसाइटोपिनिया, है ना. सो देयर कैन बी माइल्ड थ्रोम्बोसाइटोपिनिया, मतलब द काउंट विल बी बिटवीन 1 to 1.5 लाख. इसको क्या कहते हैं? व्हाट इज द रीजन? द रीजन इज फिजियोलॉजिकल. तो इसको नाम देते हैं जेस्टेशनल थ्रोम्बोसाइटोपिनिया. यस, वेरी गुड. टोटल सीरम प्रोटीन्स, सीरम प्रोटीन्स भी डिक्रीज होते हैं, इसीलिए ऑन्कोटिक प्रेशर दैट विल ऑल्सो डिक्रीज. फिर किसी ने बहुत अच्छा जवाब दिया, एक्सीलेंट. ऑल क्लॉटिंग फैक्टर्स इंक्रीज एक्सेप्ट विच वन? यस, क्लॉटिंग फैक्टर्स सारे इंक्रीज होते हैं एक्सेप्ट 11 and 13 which will show a decrease. Very nice. What happens to PCO2? It is going to decrease. PCO2, excellent, very good. Serum creatinine, blood urea nitrogen, uric acid, ये सब डिक्रीज होता है बिकॉज GFR is increasing, है ना. So all these are going to decrease. Very good. What happens to peristalsis of ureter? What happens to peristalsis of ureter? बताओ. This is going to decrease because of the effect of progesterone. Almost all physiological changes are because of primarily progesterone. Yes. So peristalsis decreases and we can come across हाइड्रोयूरेटर. कौन सी साइड पे ज्यादा होता है? राइट साइड पे. वेरी गुड, एक्सीलेंट. आई एम सो प्राउड ऑफ यू. बहुत अच्छे से याद है. गुड जॉब. राइट. सो ये बहुत इंपॉर्टेंट पैरामीटर्स हैं जो हम कह रहे हैं क्या हो रहे हैं? डिक्रीज. एनीथिंग एल्स दैट यू कैन रिमेंबर व्हिच डिक्रीजेस? सो डिक्रीज वाली चीजें प्रेगनेंसी में कम है, ज्यादातर एवरीथिंग इज गोइंग टू इंक्रीज. राइट. ओके. नाउ आई वांट टू आस्क यू, वो कौन से फिजियोलॉजिकल चेंजेस हैं विच आर बिकॉज ऑफ ईस्ट्रोजन? मैंने 4 बताए थे. व्हाट वंस आर बिकॉज ऑफ ईस्ट्रोजन? सो पिगमेंटेशन, जैसे कि लीनिया नायग्रा, ठीक है, जैसे कि क्लोआज्मा या मेलाज्मा. राइट. सो पिगमेंटेशन. फिर थायराइड बाइंडिंग ग्लोब्यूलिन, ये इंक्रीज हो जाता है अगेन बिकॉज ऑफ ईस्ट्रोजन. क्लॉटिंग फैक्टर्स इंक्रीज होते हैं, दिस इज अगेन बिकॉज ऑफ ईस्ट्रोजन. एंड वॉल्यूम एक्सपेंशन इज ऑल्सो बिकॉज ऑफ ईस्ट्रोजन. ठीक है. इज दिस क्लियर? सो ये 4 चीजें हैं विच आर प्राइमरीली बिकॉज ऑफ ईस्ट्रोजन. एवरीथिंग एल्स इज मेनली बिकॉज ऑफ व्हाट? मेनली बिकॉज ऑफ प्रोजेस्टेरॉन. ठीक. एवरीबडी गुड टू गो? सो वाज इट अ गुड समरी ऑफ फिजियोलॉजिकल चेंजेस? यस. चलो. ओके. लास्टली बिफोर आई गो टू द नेक्स्ट क्वेश्चन, कौन सा मर्मर फिजियोलॉजिकल होता है? सिस्टोलिक. यस. So systolic murmur up to grade 2 is physiological. कौन सा एक्सिस डिविएशन मिलता है हार्ट में? लेफ्ट एक्सिस डिविएशन. यस. सो लेफ्ट एक्सिस डिविएशन. यस. तो ये कुछ और चीजें हैं. एंड नॉट टू फॉरगेट लास्टली, सुपाइन हाइपोटेंशन सिंड्रोम किसकी वजह से हो रहा था? supine hypotension syndrome, remember compression of IVC. ठीक है. compression of IVC because of the big uterus. ठीक है. so remember these. चलो, good to go. let's look at the next question. modified, keyword है इसमें modified. ठीक है. modified biophysical profile includes what is the answer? बताओ. Yes, the answer is B, NST and amniotic fluid. right? So that is what is modified biophysical profile. लेकिन अगर मैं पूछूं खाली BPP, what is the other name for this? Other name is Manning's score. Yes, Manning's score. Chalo, quickly tell me the 5 components. Yes, beta, when we say amniotic fluid, it is assessed on ultrasound. है ना? और कैसे assess करेंगे? So, you have to say it has to be NST and amniotic fluid, not ultrasound. Ultrasound पे तो बहुत सारी चीजें आती हैं, है ना? So, Manning's score में आता है fetal breathing movements. Yes. What next? Gross movements of the baby. Please remember, when I say gross body movements, when I say breathing movements, या when I say fetal tone, ये सब कैसे देख रहे हैं? On ultrasound, right? We are looking at all these things on ultrasound. Then we are supposed to do a NST and we are supposed to look at amniotic fluid, जिसमें I am okay with a single pocket of 2 centimeters. Yes, पूरा amniotic fluid देखने की जरूरत नहीं है. Even if I see one pocket of 2 centimeters, then it is okay. Yes, so remember what is complete BPP and what is modified BPP. Chalo, shabash. Now I want you to look at these 3 figures. Can you tell me what deceleration is figure A, bacha? Yes, not daily fetal movement, because when you say daily fetal movement, it is perceived by the mother, jabki BPP has to be done on ultrasound. Yes, so look at image A. The dip is slow in or a slow onset and a gradual fall and a gradual pickup, and it is coinciding with the contraction. So yes, this is early deceleration. कौन सा बच्चा cause बताएगा? Yes, it is head compression and it is physiological, not to be worried about. ठीक है, last देखते हैं, image C देखते हैं पहले. It is a slow fall and a slow pickup, लेकिन it is persisting after the contraction. जब वो after contraction persist करता है, we call it as late deceleration. What is the cause? It is uteroplacental insufficiency, which is causing what? Fetal hypoxia, है ना? It is causing fetal hypoxia. So this is late. Late में it has to persist after the contraction. It usually starts जब contraction strongest होता है, तो middle में start होता है, slow fall है, slow pickup है, and it has to persist after the contraction. Yes, very good. Image B देखो, हम बोल रहे हैं it has a variable onset. कभी वो contraction के शुरू में आ जाता है, कभी contraction के peak में, कभी contraction के बाद में. So it has a variable onset, and what else? It is a quick fall and a quick pickup, है ना? Rapid fall है and rapid pickup and variable relationship to the contraction. और अगर ऐसा होगा तो क्या नाम देंगे? Variable decelerations. Yes, very good. Then we will call it as variable decelerations. कब मिलते हैं? What is the cause? Cord compression. Okay, they are because of cord compression, and they are most common type in labor. Okay, most dangerous is not variable beta. Worst outcome is with late decelerations. ठीक है, so late decelerations will have the worst outcome. ठीक है बच्चे, is that clear to everybody? सो ये दोनों चीजें याद होनी चाहिए, एनएसटी की कुछ नॉर्मल बातें एज वेल एज बायोफिजिकल प्रोफाइल एंड मॉडिफाइड बायोफिजिकल प्रोफाइल। ठीक है, गुड टू गो टू द नेक्स्ट क्वेश्चन। आगे बढ़े, चलो लेट्स लुक एट द नेक्स्ट क्वेश्चन। In which of the following situation this instrument is contraindicated? What is this? They are different types of vacuum cups, है ना? They are used for vacuum delivery, right? Which is a type of instrumental delivery. एक में सॉफ्ट कप है, एक में मेटालिक कप है और एक में नए तरीके के साइलास्टिक मशरूम कप्स हैं. सो दे आर ऑल different types of vacuum cups. So yes, very important. Preterm में vacuum is contraindicated. Now I want to ask you, can we use forceps? Yes, preterm में forceps can be used, but vacuum is contraindicated. Next question. Heart disease, can we use instruments? Yes. So both instruments can be used. Okay. Now, cervical dilatation more than 8 centimeters. Can I use a vacuum? Yes. So please remember, forceps के लिए full dilatation is mandatory. Fully dilated होना चाहिए, मगर vacuum can be applied after how much? After 6 centimeter dilatation. Full dilatation कितना होता है? 10 centimeter, right? Vacuum को हम 6 centimeter के बाद लगा सकते हैं, but please remember, vacuum के लिए भी what is preferred? Preferred is full dilatation. Okay. Maternal exhaustion, again maternal exhaustion में both instruments can be used, vacuum also as well as forceps also. ठीक है, very good. अब मुझे आपको बताना है, can you tell me, जब हम बोल रहे हैं vacuum is contraindicated, where else vacuum is contraindicated? So एक हमने बोला preterm, दूसरा important after coming head of breech, तीसरा face presentation. Okay, इन सब में vacuum is contraindicated, but in सब में forceps can be used, है ना? इन सब में forceps can be used. Okay, now both instruments, forceps as well as vacuum, कहाँ contraindicated होते हैं? मतलब वो कौन सी conditions हैं जिनमें both instruments are contraindicated? पहला, if there is what? CPD or a contracted pelvis, then yes, both instruments are contraindicated. If the baby has osteogenesis imperfecta, मतलब उसके बोन्स में ही प्रॉब्लम है. थर्ड, HIV पॉजिटिव, इन सब में दोनों ही इंस्ट्रूमेंट्स नहीं लगाने, ना फॉर्सेप्स ना वैक्यूम. यस, नाउ द लास्ट पार्ट अगेन विच इज लाइकली टू बी आस्क्ड इन द एग्जाम, कैन यू टेल मी मेम्ब्रेन्स कैसी होनी चाहिए if you have to apply the instruments? So please remember, instruments लगाने के लिए, so for instrumental delivery, membranes should be ruptured. Okay, and head कैसा होना चाहिए? Head should be engaged, है ना? ये दो बातें बेटा जी याद रखना है. Head should be engaged and membranes should be ruptured. ठीक है बच्चे? Is that clear to everybody? Very good. Now I want to ask you, okay, a important question. क्या आप मुझे बता सकते हो forceps जो है वो कौन सी fetal injury करता है? Which fetal injuries are more with forceps? So पहला आंसर brachial plexus injury, दूसरा आंसर, व्हाट इज द सेकंड आंसर? द सेकंड आंसर इज facial nerve palsy. Yes. Third, there could be lacerations of the skin. Yes. So skull fracture भी हो सकता है, laceration of facial skin and intracranial या intraventricular hemorrhage. ठीक है, सो दीज आर मोर विद फॉरसेप्स. नहीं बच्चे, सेफेल हेमेटोमा आंसर नहीं है, तभी तो मैं बता रही हूँ, सो दैट यू आर नॉट गोइंग टू डू मिस्टेक हियर. वैक्यूम कौन सी फीटल इंजरी ज्यादा करता है? सो इट इज गोइंग टू डू सिक्स्थ नर्व पैल्सी, शोल्डर डिस्टोशिया. यस, इंजरी टू द रेटिना, बच्चे का रेटिना का इंजरी एंड सेफेल हेमेटोमा. ओके, इनमें वैक्यूम इज मोर कॉमन फॉर दीज इंजरीज. ठीक है, इज दिस क्लियर टू एवरीबडी? यस, ओके, यस. अच्छा, लास्ट चीज ये मैंने क्लास में बताई है, मैं दोबारा से पूछ रही हूँ, एग्जाम में कैसे पता लगेगा कि सीपीडी है और इसीलिए इंस्ट्रूमेंट्स यूज नहीं करने? सो इफ दे टॉक अबाउट बोथ द थिंग्स, कैपेट भी हो और साथ में मोल्डिंग भी हो, सो प्रेजेंस ऑफ कैपेट एंड मोल्डिंग टुगेदर इंडिकेट व्हाट? cephalopelvic disproportion. और अगर ये लिखा हो तो इंस्ट्रूमेंटल डिलीवरी नहीं करनी है. सो यू हैव टू सी देम टुगेदर, क्योंकि माइल्ड कैपेट, ठीक है, कैन हैपन इवन इन नॉर्मल डिलीवरी. माइल्ड मोल्डिंग कैन ऑल्सो हैपन इन नॉर्मल डिलीवरी. सो इट हैज टू बी सिवियर डिग्रीज ऑफ मोल्डिंग एंड कैपेट टुगेदर, दैट विल इंडिकेट सीपीडी. ठीक है, और अगर ऐसा है तो आंसर क्या मार्क करना है? Yes, you are going to mark cesarean section. Very good. Good job. Good job. Well done. चलो आगे करें. Now this is a easy question. सारे बच्चे बताएंगे. Ideal time for evaluation of the findings shown below. What finding is this, beta ji? Yes. So we are showing you NT scan, nuchal translucency. कब करते हैं? Yes, it is done in the फर्स्ट ट्राइमेस्टर. हम बोलते हैं 11 to 13 प्लस 6 वीक्स. चलो बताओ, इंक्रीज्ड एनटी कब लेते हैं? इफ द वैल्यू इज मोर देन 3 mm. Yes, if the value is more than 3 mm, we take it as increased NT. क्या आप मुझे बता सकते हो what would be the next step if NT is increased? क्या करना चाहोगे? So you have to know increased NT का मतलब है a high risk of aneuploidy, है ना? High risk of aneuploidy. कौन सी aneuploidy? Yes, trisomy 21 followed by monosomy X. So इसीलिए if NT is increased and I am asking you next step, the next step has to be a diagnostic test. कौन सा होगा? आंसर विल बी chorionic villus sampling. Yes, answer will be chorionic villus sampling. Yes, because NT कब कर रहे हैं? फर्स्ट ट्राइमेस्टर में. तो which diagnostic test do we do in the first trimester? That is also CVS. Now, important, I want you to look at these very basic images. Can you tell me what are images 1, 2 and 3? Yes, diagnostic test का मतलब ही ये है कि we will do a karyotyping. ठीक है, उसके लिए we need a genetic material, right, for which we will do CVS. So what is 1, 2 and 3? One image क्या है? Image 1 is amniocentesis. Why? Because the needle is in the fluid. So amniocentesis. कब करते हैं बताओ? Beyond 15 weeks. Most commonly 16 to 18. ठीक है. Image number 2. sorry, image number 1 is not amnio, my mistake. Image number 1 is CVS. I was looking at 2 and writing at 1. Yes. So image number 1, correction, is chorionic villus sampling. So the needle here is in the placenta, right? So 1 is chorionic villus sampling, okay? Yes. 2 is amnio beta. This is needle in the fluid around the baby, okay? So look at this. Image number 2 is amniocentesis and 1 is chorionic villus sampling. So agar aapka needle, okay, the needle is in the placental tissue, then it is chorionic villus sampling. If the needle is in the fluid, then it is amniocentesis. Yes. So now, yes, third wala kya hai? It is in the umbilical cord. So this is chordocentesis, right? This is chordo. अब हम timing की बात करते हैं. So when do you do CVS? In the first trimester. Any time beyond equal to 10 weeks. Up to what time? Up to 13 weeks. So we will do it any time beyond 10 weeks up to 13 weeks. Amnio मैंने बताया था any time after 15 weeks. Most commonly 16 to 18. Yes. CVS कब करते हैं? Around 10 to 12 weeks. Okay. Chordocentesis beyond 18 weeks. Chordo is done beyond 18 weeks. अच्छा, एक extra question, very important. We should not do CVS before 9 weeks. कौन बताएगा why? We should not do it before 9 because this will lead to limb defects. Then, iska question, there is an entity called as early amniocentesis. वो कब करते हैं? 11 to 14 weeks. Yes, 11 to 14, but we don't do it because it will cause fetal loss, right? So because it can cause fetal loss. So chordocentesis कौन सी condition में कर रहे हैं? अभी हमने पढ़ा था. We were doing it in RH negative pregnancy when it is sensitized, right? So then we are doing a chordocentesis. Is that clear to everybody? Chalo. Very good. Good job done. Jaldi se batao, when do we do level 2 ultrasound? Level 2 ultrasound? So level 2 ultrasound is done between 18 to 22 weeks. It is also called as anomaly scan. है ना? Anomaly scan. That is what is level 2 ultrasound. So ये time periods important हैं. They are the easier ones. ज़्यादा नहीं करेंगे, but ये वाले ज़रूर करेंगे. ठीक है? Also, can you tell me best parameter for gestational age in first trimester? बताओ. Single best parameter for gestational age in the first trimester. ये है crown rump length, right? Crown length. Now, single parameter in the second trimester, biparietal diameter, right? So then it is biparietal. Now tell me, is CRL better or BPD better? CRL in the first trimester is better than BPD. क्योंकि the earlier you do the assessment, the better it is. ठीक है? जितना जल्दी करते हैं उतना correct estimation होता है. Yes. Now, where will you use CRL? When LMP is not known. या फिर when the cycles are irregular. या फिर the patient conceived while on OCPs. So if she was taking OCPs and she has got pregnant while she was taking OCPs, then we will need to do what? Yes, we will need to do gestational age with CRL. Yes, बिल्कुल सही कहा. Whenever you want to know about fetal growth, then the parameter is abdominal circumference. Okay, good job, very good. चलें आगे बढ़े. चलो, let's look at the next question. What is the chromosome number of the image shown below? So a very classic image. क्या है ये? Snowstorm. Right, so this is the snowstorm, which means we are dealing with what? We are dealing with complete mole. Do we see any fetus? No, यहाँ पे कोई भी fetus नहीं है. What exactly are you seeing here? Complete में we will see a complete hydropic change of placenta. So placenta में पानी भर गया है. So complete hydropic change of placenta. What else will you get in ultrasound of complete mole? You will get theca lutein cyst. कहाँ होते हैं? So you will see them in both the ovaries. So bilateral ovaries will show you theca lutein cyst. So ये सारे ultrasound findings हैं of complete mole. Snowstorm को और क्या कहते हैं? Yes, we also call it as honeycomb appearance. Yes, honeycomb appearance. Now, complete mole होगा तो what will be the karyotype? It is going to be 46XX. Yes, so this is the most common karyotype for complete mole. Chalo, can you tell me treatment of choice for complete mole? So if it is a complete mole, treatment of choice क्या mark करोगे? Suction and evacuation. चलो, who is going to tell me what is the surveillance period? What is the surveillance period? You will answer it as 6 months. Surveillance period after suction and evacuation is 6 months. Jaldi batao, what would be the contraception of choice? Very good. Contraception of choice will be combined oral contraceptive pills. Yes, combined oral contraceptive pills. And जब हमने बोला contraception of choice, कौन सा contraception नहीं देना? Not to be given. Intrauterine device. Okay, जब हमने बोला surveillance period, what are you using for surveillance? We will do serial levels of serum HCG, है ना? So हम पहले weekly करते हैं और फिर हम monthly करते हैं. Yes, so weekly and then monthly. So repeated हमें बार बार HCG test करना पड़ता है. It keeps coming as positive. Yes, okay, perfect. Now partial mole का karyotype क्या होता है बच्चे? It is a triploid. So 69XXY. चलो, now you have to tell me partial और complete में से which one is dispermic? कौन से dispermic होते हैं? Partial moles, they are dispermic. Complete moles are monospermic. Okay, fetus होता है? Yes, fetus is present and you will only see partial or focal hydropic change. Okay, so we will see a partial or only a focal hydropic change. ठीक है, चलो, very good. Now tell me, अगर एक patient को complete mole के बाद choriocarcinoma हो गया, how will she present? एक पेशेंट को कंप्लीट मोल के बाद कोरियोकार्सिनोमा हो गया, हाउ विल शी प्रेजेंट? शी कैन हैव ब्लीडिंग, शी कैन हैव अ एनलार्ज्ड यूटेरस, राइजिंग HCG, है ना? शी विल हैव अ राइजिंग HCG. शी कैन हैव मेटास्टेसिस, मोस्ट कॉमनली इन द lungs, right? But they can also be in the vagina, है ना? lungs में हो सकता है और vagina में हो सकता है. So as well as persistent theca lutein cyst. So ये सारे presentations आपको बताते हैं that patient has most likely converted into choriocarcinoma, ठीक है, which is a type of what? GTN, है ना, it is a type of gestational trophoblastic neoplasia, right? GTN. जी हाँ, lungs में you get cannonball images, and vagina में you will see bluish suburethral nodule, है ना, you will see a bluish suburethral nodule. Okay, जल्दी बताओ overall which is the most common GTN? Overall most common होता है invasive mole, और second most common होता है choriocarcinoma, right? So सबसे common है invasive mole, फिर आता है choriocarcinoma, फिर आता है PSTT and ETT. Okay, they are the different types of GTN. क्योंकि बहुत बार क्वेश्चन आता है all are GTN except, so please remember partial mole is not a GTN, it is a benign thing. Okay, is that clear to everybody? Chalo, very nice. Okay, quickly tell me, if a woman has metastasis in lungs, कौन सा स्टेज GTN है ये? स्टेज 3 GTN. बट प्लीज रिमेंबर ये स्टेज 3 है, बट इट हैज गुड प्रोग्नोसिस, एंड इसीलिए यू विल गिव सिंगल एजेंट. वो कौन सा एजेंट है? methotrexate. सिंगल एजेंट बट मल्टी डोज कीमोथेरेपी, ठीक है. So single agent, one only drug, but multiple doses have to be given for chemotherapy, ठीक है. So it is good prognosis, it is highly responsive to chemotherapy. Chalo, very good. Yes, vaginal metastasis is stage 2. You are absolutely right. This is going to be stage 2, and again good prognosis. Chalo, shabash. आगे बढ़ते हैं. Good to go everybody. Okay. All the following are complications of post-term pregnancy except, बताओ आंसर क्या है? Except polyhydramnios. So please remember, post-term में amniotic fluid को क्या होता है? Oligo. Right? So post-term में amniotic fluid बहुत कम हो जाता है, तो आंसर है oligo. Can you now tell me other important causes of oligo? So, ruptured membranes will also cause oligo. Then, anomalies, fetal anomalies can also cause oligo. आप मुझे बताओगे which anomaly? So, it can be renal agenesis, but it can also be a posterior urethral valve, क्योंकि वहां पे क्या हो गया है? Obstruction. So urine output has come down. So when there is decreased urine output by the baby, there will be oligo. Very good. Now, what else can cause oligo? Then intrauterine death can also cause oligo. Uteroplacental insufficiency, typically ये करेगा ओलाइगो इन दी 3rd trimester, जबकि अनोमलीज कब करती हैं बताओ? अनोमलीज विल कॉज ओलाइगो इन 2nd trimester. Then oligo can also be seen in twin transfusion syndrome. Remember, one baby oligo, one baby poly, and it can also be seen with torch group of infections. So remember, ये बेटा जी important है, causes of oligo, ठीक है. And अगर हमने पूछा एक patient को oligo है, what is the next step? तो सबसे पहले क्या करना है? Per speculum examination to look for ruptured membranes. उसके बाद क्या करना है? Ultrasound. राइट. सो सबसे पहले डू अ परस्पेक्युलम एग्जामिनेशन एंड उसके बाद डू अ अल्ट्रासाउंड. यस, ओके. नाउ कैन यू टेल मी ये तीनों इमेजेस किस चीज की हैं? देयर इज इमेज 1, 2 एंड 3. ये सब किसकी इमेजेस हैं? They are all images of anencephaly. Yes, they are all images of anencephaly. Right? Now, पहला है gross image. दूसरे में क्या है? Frog eye sign. Right? So, this is the frog eye sign. Prominent eyes. और image 3 में देखो क्या है? You are seeing the spine. ये बच्चे की spine है, मगर यहाँ पे हेड इज एब्सेंट, है ना? पूरा स्कल एंड क्रेनियम एवरीथिंग इज एब्सेंट. सो दे आर ऑल इमेजेस ऑफ एनेंसेफेली. मुझे बताओ एनेंसेफेली में विल यू सी ओलाइगो और विल यू सी पॉली? सो एनेंसेफेली में क्या मिलता है? पॉली, बिकॉज ऑफ absent or reduced swallowing. Okay, can you tell me image number 4? ये तो labeled ही है. What is image number 4? Image 4 में दो sign दिख रहे हैं. There is a lemon sign, there is a banana sign. ठीक है, this is a banana shaped cerebellum. और यहाँ पे क्या बन रहा है? फ्रंटल बोन्स जो कॉन्केविटी वो डिप्रेस्ड हैं. सो डिप्रेस्ड फ्रंटल बोन्स, व्हाट इज इट अ मार्कर ऑफ? ये दोनों चीजें किसके साइन हैं? दे आर साइंस ऑफ स्पाइना बाइफिडा. राइट, सो दे आर साइंस ऑफ स्पाइना बाइफिडा. वेरी गुड. उसमें भी क्या मिलेगा? अगेन polyhydra amnios. The reason is again reduced swallowing. Yes. तीसरा important cause, I want you to look at this. Can you tell me what is image number 5? Let's put it as 5. ये क्या है image number 5? Sacral agenesis, जिसका दूसरा नाम क्या है? Caudal regression syndrome. किस कंडीशन में मिलता है बताओ? Yes, it is seen in diabetes, but I want to ask you, which diabetes? Pre-gestational. Yes, so this is seen in pre-gestational diabetes, not in gestational. Gestational में anomalies नहीं मिलती. So it is seen in pre-gestational. And is it the most common anomaly or most specific? It is the most specific anomaly. Most common कौन सी होती है? Most common anomaly होती है VSD. Okay, so most specific है sacral agenesis, most common है VSD. मुझे बताओ, why are we talking about this in polyhydra amnios? Because diabetes is the third important cause of polyhydra amnios. So apart from anomalies, it could be neural tube defects या anencephaly, दोनों ही neural tube defects हैं, spina bifida, anencephaly. Yes, then abdominal wall defects can also cause polyhydra amnios, है ना? So any GIT anomalies can also cause polyhydra amnios. So please remember, चाहे वो duodenal atresia हो या वो cleft palate हो, wherever the swallowing is reduced. ठीक है? Yes. So diabetes is the third important cause. Can you tell me other important causes? So remember, whenever there is hydrops fetalis, so जब बच्चे का हार्ट फेल हो रहा होगा, it will also cause polyhydra amnios. Tell me two important causes of hydrops fetalis. So it can be due to infections like parvovirus या syphilis, या it could be because of RH negative pregnancy. right? So जहाँ पे भी hydrops होगा, there can be polyhydramnios. Then twin transfusion syndrome. I told you one baby is poly, one is oligo. Yes, so it is also a important cause. And last में हम uncommon चीजें रखेंगे, जैसे कि fetal barter syndrome. बार्टर सिंड्रोम में भी क्या होता है, पॉलीयूरिया, राइट? सो अगर पॉलीयूरिया होगा देन ऑल्सो देर इज पॉलीहाइड्रामनियोज. हाइड्रॉप्स में भी एक्चुअली क्या होता है, पॉलीयूरिया, विच लीड्स टू पॉलीहाइड्रामनियोज. ठीक है, सो गुड टू गो एवरीवन. So poly or LIGO causes you should be able to answer, and indirect और direct question दोनों आते हैं. ठीक है, are we good to go? चलो शाबाश. Let's go on to the next question. Which of these steps is followed for the management of shoulder dystocia after the shown maneuver fails? कौन सा maneuver है ये? Which maneuver is this? So this is MacRoberts, right? This is the first maneuver जो हम किसके साथ करते हैं, legs के साथ. There is a sudden abduction and flexion. So leg को हमने abduction करना है, flexion करना है. So if this fails, then what do? Then the next step has to be suprapubic pressure, right? So MacRoberts के बाद हम करते हैं suprapubic pressure. ठीक है बच्चा, is that clear? Then you can do a delivery of posterior arm. ठीक है, उसके बाद we can try and deliver the posterior arm, and then we can do the rotational maneuvers. ये internal maneuvers होते हैं. Can you tell me name of two rotational maneuvers? So एक का नाम होता है Wood's corkscrew और एक का नाम होता है रूबीन. कैन यू टेल मी द लास्ट मैनूवर? लास्ट मैनूवर कौन सा होता है, जावा नेली. यस, द लास्ट मैनूवर इज जावा नेली. वे आर गोइंग टू पुश बैक द बेबी एंड डू अ सिजेरियन सेक्शन. ओके, कैन यू टेल मी विच डिस्ट्रक्टिव प्रोसीजर कैन आई डू? कौन सा एक डिस्ट्रक्टिव प्रोसीजर है जो हम कर सकते हैं? द आंसर इज क्लीडोटमी. क्या होता है बेटा क्लीडोटमी? क्लीडोटमी वेयर यू कट द एंटीरियर क्लैविकल. तो ये भी किसमें कर सकते हैं, शोल्डर डिस्टोशिया. सो वी कैन डू क्लीडोटमी. The only destructive procedure that we do in modern obstetrics is cledotomy. ठीक है बच्चा, is that clear? Please do not mark symphysiotomy. वो हम नहीं करते. Symphysiotomy is not done. We don't cut the symphysis pubis. We can cut the clavicle. Okay. Then I want to ask you, should we give fundal pressure? No. So please remember, no fundal pressure in shoulder dystocia. Should I ask the mother to push or ask her not to push? क्या बोलोगे पेशेंट को, बताओ? Ask the patient not to push. Normally obstetrics में हम हमेशा बोलते हैं push, 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 right? Shoulder dystocia में you will tell her not to push. So no fundal pressure, do not push. Yes. Should I give an episiotomy? Yes, episiotomy to be given. And should I empty the bladder? Yes, we should empty the bladder. So give episiotomy, empty the bladder and do the maneuvers. ठीक है? So this is important for shoulder dystocia. किस में मिलता है बच्चे shoulder dystocia? शोल्डर डिस्टोशिया मिलेगा मैक्रोजोमिया. एंड इफ इट इज मैक्रोजोमिया, विच प्रेगनेंसी? डायबिटीज, राइट? सो शोल्डर डिस्टोशिया इज टिपिकली सीन इन अ डायबिटिक प्रेगनेंसी. यस, इज दिस क्लियर? चलो, गुड टू गो. गुड. I am proud. आप लोग बहुत अच्छे से आंसर कर रहे हो, and I'm sure that this FMG exam is going to be rocking for all of you. So lots of good wishes. Please पूरे confidence से जाओ और एकदम फोड़ कर आओ, ठीक है? Promise? Will you do that? Okay. Let's look at the next question. How will you deliver these babies? So this is a twin pregnancy. Yes, so this is a twin pregnancy. And can you tell me what is the first twin? First twin कौन सा है? This is the first twin. Why? क्योंकि ये नीचे है, which means this will enter the pelvis first. And this is the second twin, right? So पहला twin क्या है? The first twin is breech, which means it is non-vertex. So whenever the first twin is non-vertex, management क्या होता है? Caesarean section. So first twin is breech, the second is cephalic. So whenever the first twin is non-vertex or non-cephalic, we will do a Caesarean section. So the answer is Caesarean. Can I do a external cephalic version? No. So बच्चे याद रखोगे, external cephalic version is contraindicated in twin pregnancy. One baby delivers, उसके बाद आप कर सकते हो. So ECV is only done with a single ton pregnancy, not with twins. Yes? Okay. IPV with breech extraction किस में करते हैं? ये करते हैं when the first twin is vertex and वो deliver कर जाए. So the first twin is vertex and the baby delivers. And the second twin is transverse lie. Yes, that's when you will do a IPV with breech extraction. This is the only indication. सिर्फ एक ही indication होता है OBS में. Okay? Vaginal delivery नहीं कर सकते. Can you tell me, if I do a vaginal delivery when the first twin is breech and second is vertex, what complication can happen? कौन बताएगा? When first is breech and second is vertex, what complication can happen? The complication is called as twin interlocking. And then I will have to do a emergency cesarean. इसीलिए we are not going to do a vaginal delivery, right? So we will do a cesarean section. So it is called as twin interlocking. कभी कभी ये direct MCQ आता है. Twin interlocking is seen in which twins? So when the first is breech and the second is vertex, दोनों के head आपस में अटक जाते हैं. Both the heads, the head of the first twin and the second twin get locked. Then you will have to do a emergency cesarean. ठीक है? Now, can you tell me the named sign written here? It's called as a lambda sign. Can you tell me in which type of twins will you see the lambda sign? So this is seen in monochorionic and, am I right? No. So this is seen in dichorionic and diamniotic. So lambda sign is DCDA, whereas T sign is seen in monochorionic and diamniotic. So lambda sign is DCDA and T sign is MCDA. Yes? मुझे बताओ, when it is dichorionic, right? Placenta कितने होंगे? There will be 2 placenta, right? Dichorionic मतलब 2 placentas. Yes, they can fuse and look like one, but actually there are 2 placentas. ठीक है? So DCDA. MCDA मतलब 1 placenta. और अगर 1 placenta is going to give blood to both babies, what is going to happen? There will be vascular communications. So can you tell me most characteristic complication कौन सी होती है? So हमने बताया the most characteristic complication here is twin transfusion syndrome, TTTS. Yes, so twin transfusion syndrome is seen in monochorionic and diamniotic. ठीक है, who is going to tell me what is the name of scoring system? Anybody remembers the name of the scoring system? It is called as Quintero. Quintero. Okay. Now, quickly tell me, stage 1 Quintero में क्या मिलता है? There is poly in one twin, oligo in the other twin, and bladder is visible. That is stage 1. Stage 2 क्या होता है? There is poly, there is oligo, bladder is not visible. Yes? Okay, stage 3. There is poly, oligo, bladder is not visible, और साथ में अब क्या होगा? There will be Doppler abnormalities. Okay, so abnormal Doppler. ठीक है, there will be abnormal Doppler. 4 में क्या होता है? Either one or both the twins will show what? Hydrops. So either one or both show hydrops. और 5 में क्या होता है? Either one or both the twins are going to die. So intrauterine death. कौन से vascular communications में होता है? Deep artery connected to a deep vein. और मैनेजमेंट क्या बताया था? मैनेजमेंट इज यस लेजर एब्लेशन. ओके, सो ये जो वैस्कुलर एनास्टोमोसिस है उनका लेजर एब्लेशन. ओके बच्चे, मैंने पहले भी बताया, आई हैव शेयर्ड द पीडीएफ इवन yesterday itself after the session in my telegram channel as well as in DAMS का FMG channel specially. आज वाला भी I will share, don't worry. Okay, what is this? One is a pump twin, the other is a cardiac twin. ये क्या होता है? Twin reversed arterial perfusion. Yes, so twin reversed arterial perfusion. A cardiac twin is like a parasite. So this is also a parasitic twin. It is taking blood from the other baby. What are the connections? Artery to artery connections. Again seen in monochorionic and diamniotic twins. ठीक है? So seen in monochorionic and diamniotic twins. ठीक है बच्चा? Is that clear? Okay. TAPS. TAPS याद रख लो, twin anemia and polycythemia sequence. I told you, let me see कौन याद दिलाएगा. How is this different from twin transfusion? यहाँ पे one baby will have anemia, the other baby will have polycythemia, but क्या नहीं मिलेगा? No abnormalities of Leica. When there are abnormalities of Leica, it becomes twin transfusion. So there will be no abnormality of amniotic fluid. Then it is called as TAPS. Okay, twin anemia and polycythemia sequence. ये भी किस में मिलता है? Monochorionic twins. Okay, monochorionic twins. Again कनेक्शंस होते हैं यहाँ पे सुपरफिशियल आर्टरी टू सुपरफिशियल वेन. दीज आर सुपरफिशियल वेसल्स. लेकिन यहाँ पे कैसा था? डीप. ट्विन ट्रांसफ्यूजन सिंड्रोम के लिए इट हैज टू बी डीप वेसल्स. ओके, चलो लेट्स गो ऑन टू द नेक्स्ट क्वेश्चन. जल्दी जल्दी देखते हैं. ओके, सो ऑल द फॉलोइंग आर सीन विद एब्रप्शन एक्सेप्ट. व्हाट इज द आंसर? It is warning hemorrhages. Warning hemorrhages किस में मिलते हैं? Placenta previa. Yes, so these are seen with placenta previa. Now, quickly, Fundal height more than POG, this is true. Fetal distress, yes, it is true. It is more common in abruption. Tense, tender uterus, again it is true. Placenta previa में fundal height is same. It is a non-tense uterus, right? Non-tender and it is relaxed, है ना? यहाँ पे bleeding कैसी होती है? Bright red and painless with what? Warning hemorrhage. ठीक है? So warning hemorrhage ये बहुत important है राजे. Abruption में कैसी bleeding होती है? Dark, है ना, जिसको हम बोलते हैं altered. So it is dark and it is associated with pain. So it is painful. और यहाँ कोई warning hemorrhage नहीं होते. Pre-eclampsia किसके साथ associated है? Abruption. So please remember, pre-eclampsia is a risk factor for abruption. Very important. मगर remember, placenta previa and pre-eclampsia साथ साथ नहीं होते. Yes, they don't occur together, but abruption or pre-eclampsia occur together. Placenta previa में अगर risk पूछना होगा तो किसका पूछेंगे? The risk factor here is previous cesarean. Yes, so यहाँ पे risk factor होता है previous cesarean. That is for placenta previa. Okay, very good. ये बताओ कौन सा है? So this is called as cuvilar uterus. किस में मिलता है? Abruption. What else do we call it? We call it as uteroplacental apoplexy. ठीक है? Uteroplacental apoplexy. Please remember, cuvilar में there is a increased risk of PPH. मगर directly hysterectomy नहीं करनी. Okay? PPH होगा तो we will manage PPH, but directly hysterectomy नहीं करनी. Okay? ये photos बार बार आपके एग्जाम्स में आती हैं. So remember, type 1 is also called as low-lying placenta, जिसका मतलब है the placenta will be within 2 centimeters of internal os. ठीक है? Type 2 को हम कहते हैं marginal, because placenta is reaching the margin of internal os. Okay, it reaches margin of internal os. Type 3 को हम कहते हैं partial. बच्चे इसका मतलब समझो. इसका मतलब ये नहीं है कि partially covering os, मतलब होता है only a part of placenta. So partial part of placenta is over the os. ठीक है? Whereas type 4 को हम कहते हैं complete, because complete placenta is over the internal os, also called as central. ठीक है? So also called as central. Now please ध्यान दे दो, placenta previa में always you will do a cesarean section. मतलब even if the baby is dead, आंसर क्या होगा? Cesarean. Never answer vaginal delivery. मगर so even with absent FHR we will do a cesarean. But अगर हमने बोला abruption है and there is absent FHR, तो क्या करना है? Then you will answer vaginal delivery. ठीक है? Then we will answer vaginal delivery. Also, अगर लिखा है abruption with distress, तब आंसर बदलोगे. Then you will answer cesarean section. So abruption में vaginal delivery is the preferred route. Placenta previa में it is always a cesarean section. ठीक है? So don't do this गलती. Okay? चलो, very good. आगे बढ़े. Let's look at the next question. ये तो मुश्किल नहीं था. Have you done this one right? सो 10 वीक्स प्रेग्नेंट है, शी हैज कम विथ पेन एंड ब्लीडिंग। जैसे ही हम पेन और ब्लीडिंग का सोचते हैं, we have to think of this can be ectopic, this can be abortion. ठीक है, so please remember this. Okay, हाँ, प्लासेंटा प्रीविया में कंजर्वेटिव करते हो, बट हम बात कर रहे हैं मोड ऑफ डिलीवरी। जब भी आपको डिलीवरी करना है प्लासेंटा प्रीविया में, द मोड इज ऑलवेज सिजेरियन इज व्हाट वी आर सेइंग। ओके, ऑन एग्जामिनेशन यूट्रस इज 10 वीक्स, इसका मतलब ये एक्टोपिक नहीं है, द प्रेगनेंसी इज इनसाइड द यूट्रस। एंड डज द साइज कॉरेस्पॉन्ड टू पीओजी? यस, साइज इज कॉरेस्पॉन्डिंग टू पीरियड ऑफ जेस्टेशन, है ना। देन os is open, os is open. Now products of conception are seen. अब मुझे बताओ, it cannot be missed and it cannot be threatened, क्योंकि यहाँ पे os should be closed, है ना। इन दोनों में os कैसा होना चाहिए? Closed. इन दोनों में os is open. Now tell me, why is the answer inevitable? Because conception products कहाँ दिख रहे हैं? They are seen in the uterus, not in the cervical canal. So if it is incomplete abortion, तो कहाँ मिलेगा? Incomplete में products are seen in cervical canal. ठीक है बेटा, नॉट इनसाइड द यूट्रस, बिकॉज वो एक्सपेल होना शुरू हो गए हैं। और इनकम्प्लीट में द साइज ऑफ द यूट्रस इज गोइंग टू बी लेस देन पीओजी, बिकॉज समथिंग इज एक्सपेल्ड आउट। सो यहाँ आंसर है इनएविटेबल अबॉर्शन। वेरी गुड, आई थिंक मेजॉरिटी बच्चों ने इसको बिल्कुल सही किया है। सो गुड, आई एम हैप्पी कि आपने ये क्वेश्चन सही किया है। वी आर प्राउड ऑफ यू। ओके, चलो, वेरी गुड। हाउ विल यू डिफरेंशिएट थ्रेटेंड एंड मिस्ड अबॉर्शन? सो थ्रेटेंड में, मिस्ड अबॉर्शन में और कंप्लीट अबॉर्शन में, इन तीनों में द ऑस इज ओपन। यस, यहाँ पे द ऑस इज ओपन, ओके, और क्लोज्ड, क्लोज्ड। तीनों में द ऑस इज क्लोज्ड। ओनली इन इनकम्प्लीट एंड इन इनएविटेबल ऑस ओपन होता है। इन तीनों में, थ्रेटेंड अबॉर्शन, मिस्ड अबॉर्शन, कंप्लीट अबॉर्शन, द ऑस इज क्लोज्ड। ओके, कैसे फर्क करना है? इन कंप्लीट अबॉर्शन में ऑल प्रोडक्ट्स आर एक्सपेल्ड, whereas in threatened and missed no products are expelled, है ना। यहाँ पे nothing has come out of the uterus, so no products are expelled. So now how do we differentiate between threatened and missed? Threatened में cardiac activity is present और missed में cardiac activity is absent. Also threatened में uterine size is same as POG and missed abortion में क्या होगा? uterine size is less than POG. ठीक है, so this is how you will differentiate the various types of abortions in clinical case scenarios, right? आगे बढ़े, good to go? चलो, very good. Now your patient is a case of transverse lie. She is already in labor for last 8 hours. Cervix fully dilate हो चुका है. Membranes are absent. Presenting part is shoulder. Yes, so when you say it is transverse lie, it is shoulder presentation. कौन सी presentation होती है? Shoulder presentation. ठीक है, नहीं शुभम बच्चा, कार्डियक एक्टिविटी इज प्रेजेंट इन थ्रेटेंड एंड इट इज एब्सेंट इन मिस्ड। बहुत आसान है, मिस्ड में मिस्ड कार्डियक एक्टिविटी, ओके। FHR इज एब्सेंट। अब क्या करना है? This is the second place where even if the baby is dead. Yes? तो मुझे बताओ क्या होगा? Again, the answer will remain as cesarean. Transverse lie में vaginal delivery is not possible, right? So even if the baby is dead, you have to do a cesarean. तीसरी कौन सी condition होती है जहां dead baby में cesarean करते हैं? So then the third is obstructed labor. So here also, if there is obstruction and fetal heart rate is absent, still we will do a cesarean section. So ये तीन conditions हैं, placenta previa, transverse lie and obstructed labor. Even if the baby is absent, I mean the fetal heart rate is absent, we will still do a cesarean section. ठीक है? Is that good for everyone? Okay. Now question बदल देती हूँ, देखते हैं आप क्या आंसर करोगे. Your patient is a case of transverse lie at 37 weeks. अभी क्या करना है? So if she is a case of transverse lie at 37 weeks, क्या करना है? So exam में whether they give you transverse lie or they give you breech at 37 weeks, the management has to be external cephalic version. Okay, the best time or ideal time for ECV is 37 weeks, although it can be done any time beyond 36, but ideal time is 37 weeks. So हम इसे घुमाने की कोशिश करेंगे. So we will do ECV if there are no contraindications. So अगर कोई contraindication नहीं है, then what are you going to do? Then you will do ECV. अब मुझे बताओ, what are important contraindications for ECV? क्योंकि ये आपके एग्जाम में क्वेश्चन वाले बार बार कंफ्यूज करते हैं. So remember, if the membranes are ruptured, it is a contraindication. Twin pregnancy is a contraindication. Footling breech या stargazer baby is a contraindication. Placenta previa या contracted pelvis is a important contraindication. Fetal distress या active labor is a contraindication. इसके अलावा specially exams are going to ask you this. Remember, pre-eclampsia, okay, previous cesarean, IUGR and oligo, they are also contraindications. इनमें we don't want to do a ECV. हमारा preference होता है to do a cesarean section. Right? So please remember ये important वाले हैं. इसके अलावा yes, if the baby is too big, macrosomia मतलब birth weight more than 4 kgs, again we will not do a ECV. ठीक है? So these are important. The list is endless. So अगर कोई yes fetal anomaly हो या uterine anomaly हो, then again आप ECV नहीं कर पाओगे. So they are also contraindications. So remember, if there are no contraindications, तो आपने क्या करना है? External cephalic version. और अगर contraindications होंगी तो क्या करोगे? Cesarean section. So transverse lie में and in breech, the preferred mode of delivery is cesarean. Is that clear to everybody? Yes? So please remember this. बेटा placenta previa है तो obviously vasa previa भी contraindication होगा. हमारी लिस्ट खत्म ही नहीं होगी. Go with concepts. जहाँ पे vaginal delivery cannot be done, वहाँ पे we cannot or should not be doing a ECV. ठीक है बच्चे? Is this okay? Yes? All right. Now I only want to ask you this. Suppose there is transverse lie at 37 weeks and ECV is contraindicated, तो क्या करोगे? So चाहे transverse lie हो या breech हो, and if ECV is contraindicated, then what is the management? जैसे मैंने बोला आंसर है cesarean, but अभी नहीं करना. Cesarean will be done at 39 weeks. उससे पहले cesarean नहीं करना. This is where they will confuse you. Elective cesarean should be done at 39 weeks. ठीक है, good to go everyone. चलो आगे बढ़ते हैं. Let's go on to the next question. Okay, your patient undergoes induction of labor. 6 hours के बाद she is getting 4 contractions in 10 minutes. She is already fully dilated, right? And the head is on the perineum. Are we dealing with obstructed or rather I should say second stage arrest? Yes, this is second stage arrest. What is the criteria in primigravida? No descent. For how many hours? For 3 hours. So हमें तो actually 3 घंटे के बाद ही we should have done something. Yes. What is the criteria in multigravidas? It is going to be, yes, 2 hours, right? So 3 hours in primi and 2 hours in multi. So she is in second stage arrest. और अभी मुझे पता लगा है that fetal heart rate is dipping. But now look at this. When fetal heart rate is dipping, can I do a cesarean section as well as instrumental? Yes. This is the difference in second stage arrest. Okay. Second stage arrest में even with fetal distress, we can do both. We can do a cesarean and we can also do instrumental delivery, right? कैसे decide करोगे? यहाँ पे already लिखा है head is on the perineum, एकदम नीचे आया है. So head on perineum and no CPD. तो हम क्या करेंगे? Instrumental delivery. Now मैंने अभी आपको बताया था कैपेट इज सीपीडी, बट मैंने क्या बताया था? इट हैज टू बी कैपेट एंड मोल्डिंग टुगेदर. यहाँ क्लियरली मेंशन किया है देयर इज नो मोल्डिंग. अगर मैं यहाँ मोल्डिंग भी लिख देती तो ये सीपीडी हो जाता और आंसर होता सिजेरियन सेक्शन. इस क्वेश्चन में बहुत क्लियरली लिखा है दैट देयर इज नो मोल्डिंग. Which means, is there any CPD? No. So because there is no molding, no CPD, head is on the perineum, हमारा आंसर क्या होगा? Instrumental delivery. पहले मुझे सब बच्चे बताओ, is this clear? Yes. So अभी आंसर cesarean नहीं है, आंसर है instrumental. Yes. अब instrument में हमारे पास 2 options हैं. Yes. Vacuum and forceps. Why is the answer forceps and not vacuum? Because there is a caput. Caput क्या होता है? Swelling of the scalp. अगर scalp swelling है तो can you apply a vacuum? नहीं, vacuum वहां आसानी से नहीं लगेगा. Vacuum is more likely to fail. So because caput is present, what are we going to do? We are going to put a forceps. So caput में vacuum is more likely to fail. So it was a little tricky question, मगर ये important है. आपके FMG एग्जाम में भी applied MCQs आ रहे हैं, इसलिए I have ensured कि आपके प्रिडिक्टर सीरीज में हर तरह के क्वेश्चन हो, कुछ डायरेक्ट, कुछ अप्लाइड, कुछ इमेज बेस्ड, right? So everybody, is it clear? सिजेरियन क्यों नहीं करना? बिकॉज देर इज नो CPD. अगर मैं देती कैपेट एंड मोल्डिंग बोथ तो आंसर क्या होता? तब आंसर हो जाता सिजेरियन, because then it means there is a CPD. Is this clear? Now the answer is instrumental, but we are preferring forceps here because there is a caput. Yes, good to go? Chalo. You should all be able to identify Wrigley's forceps, बच्चे. ये Wrigley's है. कैसे पहचानते हो? With the lock. Wrigley's is a short forceps. ठीक है? So Wrigley's beta G is a short forceps and it has a English lock जो interlock हो रहा है, right? So we call it as a English lock. Wrigley's कौन सी तरह की forceps है? Wrigley's is a outlet forceps. Okay? Outlet कब बोलते हैं? Outlet बोलते हैं when the station is more than or equal to +3. Okay? Yes? So please remember, right? Station is more than or equal to +3 तो वो outlet forceps होता है. But Wrigley's can also be used as which forceps? As low forceps. ठीक है? It can also be used as low forceps. Low का मतलब है station is more than or equal to +2 but has not reached where? The perineum. ठीक है? It has not reached perineum or pelvic floor. ठीक है? Is that clear? Yes? So please remember this. कि Wrigley's को अगर पूछेंगे कौन सी forceps है तो no doubt it is a outlet forceps, but it is also used as low forceps. Is this clear to everybody? Yes? Chalo. Please remember between 0 and 2 we call it as mid cavity. यहाँ पे हम forceps अब यूज नहीं करते, पुराने जमाने में करते थे. Here we can use a vacuum. Yes, so अगर engaged है then yes you can use a vacuum. I hope you all remember station 0 मतलब the head is engaged. So between 0 and +2 it is mid cavity. मॉडर्न ऑब्स्टेट्रिक्स में हम मिड कैविटी फॉर्सेप्स यूज नहीं करते, राइट? मगर हम कौन सा इंस्ट्रूमेंट यूज कर सकते हैं? वैक्यूम. इज दिस क्लियर टू एवरीबॉडी? यस. सो अगर आपको इफ आई नाउ आस्क डीप ट्रांसवर्स अरेस्ट एंड नो CPD, यस, डीप ट्रांसवर्स अरेस्ट, नो CPD, नॉर्मल पेल्विस, तो क्या करोगे? What would be the management? कौन बताएगा? Because there is no CPD, इसीलिए we will not mark cesarean. Yes? Because pelvis is normal, we will mark instrumental delivery. अब मुझे बताओ कौन सा इंस्ट्रूमेंट यूज करोगे? So because it is deep transverse arrest, इसका मतलब it is at the level of ischial spines. And what is the level of ischial spines? 0 station. So can I use forceps? नहीं बाबा, अभी मैंने बताया इतने हाई में forceps नहीं लगाते. So now the preferred instrument will be vacuum. Is this clear to everyone? Very good. Yes, I hope अभी ये सारे case scenarios clear हों. ठीक है बच्चा? चलो, now we have a easier question. So एक difficult के बाद एक आसान सवाल, so that you don't feel disheartened. Don't worry, हाँ हमारा purpose है to learn to get better, है ना? चलो, fertilized ovum reaches uterine cavity by, so it reaches the cavity by 4 to 5 days after fertilization, which means it is going to enter in what stage? Morula, right? 16 cell stage. नहीं बेटा, please remember 6 to 7 days after fertilization क्या होता है? This is when implantation begins. This is not when it enters. ये है when implantation begins. And 10 to 11 क्या होता है? This is when implantation completes. Single best answer क्या है? Day 10. कौन बताएगा मुझे implantation is in what stage? It is in blastocyst stage. Yes. और blastocyst कब बनता है? It is formed on day 5. Yes. Okay. When is zona pellucida lost, bacha? So remember, zona pellucida lost on day 5, जिसको हम कहते हैं zona hatching. Okay, zona hatching. उसका आंसर भी क्या है? Day 5. Okay. So whenever we ask you about implantation, अगर लिखा नहीं है when does it begin or end, तो हमेशा give the answer for end. अगर specially पूछा है when does it begin, then the answer is day 6 to day 7. That's when it begins. ठीक है? Is that clear? Okay. Implantation कहाँ होता है? कौन बताएगा? Implantation का site is upper posterior wall. And remember, the implantation is eccentric, away from center. Implantation bleeding का नाम, sign का नाम, Hartmann. Hartmann. Now, can you tell me which pregnancy sign, named sign, is based on eccentric implantation? So, named sign based on eccentric implantation is Pisca sex sign, which is what? Presumptive, probable or positive? It is a probable sign because it is seen by the doctor, है ना? So it is a probable sign and it comes at 8 weeks. कौन बच्चा मुझे बताएगा 6 weeks पे? What sign do you see at 6 weeks? 6 weeks पे we will see Hagar's and we will see Goodle. Hagar is softening of isthmus and Goodle is softening of cervix. बाकी सारे named signs, चाहे वो Ozyanders हो, yes, Pisca sex is because of it is a asymmetric growth because of eccentric implantation. ठीक है? So because implantation is eccentric, तभी वो initial growth is not symmetrical. Okay? Ozyanders was lateral vaginal fornix का pulsations, 8 weeks, and Chadwick sign, Chadwick's also called as Jacqueminier's, bluish discoloration of vagina. Yes, so this is again going to be at 8 weeks. And कौन बच्चा मुझे बताएगा the named sign for regular rhythmic contractions? Yes, it is the Palmer's sign. So these are Braxton Hicks contractions. Again कब आती हैं? 8 weeks. Okay, 8 weeks. Very good. Good job. ये important है. बार बार आपके एग्जाम में आता है. So that is why I wanted you to revise. So which brings us to the last 2 questions of the day. So this is what instrument? Carmen's cannula. Okay, this is the Carmen's cannula. Very good. And it is used up to what? 12 weeks. Why? Because suction evacuation can be done up to 12 weeks. Yes. So suction evacuation is the method of first trimester abortion. Can you tell me other methods of first trimester abortion? So it can be MVA. Yes, manual vacuum aspiration, and it can be medical abortion. Medical abortion कब तक कर सकते हैं? Up to 9 weeks. What drugs do we use? We use tab, Miffy, yes, yeah, RU486 200 milligram oral. उसके बाद after 48 hours tab Mizo 800 micrograms. It can be given oral, vaginal, even sublingual. Very good, perfect, very good. So these are methods of first trimester abortion. ये क्या है? MVA syringe. MVA syringe का capacity कितना होता है? 60 ml. Pressure 660 millimeters of mercury. या फिर 600 millimeters of mercury, which is also the pressure in suction evacuation, है ना? Suction evacuation में भी it is 600 millimeters of mercury. Okay. Then please remember this. This is used up to, as I mentioned, 12 weeks, and there is no need of electricity. हमें suction machine नहीं चाहिए. Yes, we are going to do a manual suction with it. ठीक है बच्चा? Is this clear? Okay. Carmen's cannula का size क्या होता है? Size will correspond to period of gestation. Okay. And अगर इससे perforation हो जाए तो क्या करना है? Laparoscopy. Then we will go ahead and do a laparoscopy. Okay, very good, perfect, very good. Now lastly, can you tell me methods of second trimester abortion? कौन से methods हैं? So most commonly we will use prostaglandins, जिसमें we can use E1 also, E2 also, and F2 alpha also. Most common is E1. ठीक है? Then we can use extra amniotic. कौन सी drug? Ethacridine. And what will we put intra amniotic? Intra amniotic डालेंगे saline, right? So intra amniotic saline, extra amniotic ethacridine. We can also use oxytocin, but not a preferred method, है ना? Yes. Then please remember, we can also use a surgical method. What is the name of the surgical method? D and E, not D and C. वो अलग है. Dilatation and curettage was an older method for first trimester abortion. Second में कौन सा use करते हैं? Dilatation and evacuation, not curettage. Okay, is that clear? Yes. PGE1 मतलब Mizo 400 micrograms every 3 to 4 hourly for a maximum of 5 doses in the second trimester. ठीक है? F2 alpha होता है carboprost. Can I use it for abortions? Yes. But can I use it for induction of labor? No. Carboprost induction के लिए use नहीं करना. Carboprost active management of third stage and of labor के लिए नहीं करना. Right? So do not use it in AMTSL. Do not use it for induction. Can I use it for treatment of PPH? Yes. ठीक है? It can be used for treatment of PPH. ठीक है बच्चा? चलो. Let's move on to the last question. So which maneuver is shown below? So this is a breech baby. Buttocks have delivered. Body has delivered. क्या रह गया है? After coming head. Yes, this is after coming head. ठीक है? So now हमने क्या करा है, वी आर होल्डिंग द लेग्स एंड टेकिंग इट अपवर्ड. सो दिस इज व्हाट इज बर्न्स मार्शल. Yes, this is what is Burns Marshall. Now I want you to tell me what is figure 1. This is MSV. Okay, MSV. And ये भी किसके लिए यूज होता है, आफ्टर कमिंग हेड. Okay, after coming head, that is MSV. Okay, who is going to tell me what is image 2? Now ध्यान देना बच्चा, ये image 2, it looks like Burns Marshall. It is not Burns Marshall. The spine is posterior. जब spine posterior होता है, then this is Prague's maneuver, used again for after coming head when the spine is posterior. So please remember Burns Marshall. देखो फिर से, Burns Marshall में spine is anterior. ठीक है, here the spine is anterior. Prague's में the spine is posterior. Okay, then what maneuver is this? Already लिखा है Pinard maneuver. किसके लिए यूज होता है, extended legs. So extended legs के लिए Pinard's maneuver, right? And what is this maneuver? This is called as lobsets, जिसमें आप बेबी को पकड़ के रोटेट कर रहे हो. We are rotating the baby first to one side and then to the other side. So this is lobsets used for extended arms, delivery of extended arms. Okay, is that clear? So Pinard is for the delivery of extended legs and lobsets is for the delivery of extended arms. Okay, all right. You must be able to identify, ठीक है, frank breech is also called as extended breech because the legs are in extension. Look at the knee joint. Knee joint कैसा है, extension में है. So this is extended breech. Complete is called as flexed breech. इसमें दोनों joints, hip joint और knee joint, दोनों ही flexed हैं. So this is a complete breech. Footling में one or both feet are down. This is also called as incomplete breech. चलो जल्दी से बताओ, which is most common? Frank. Okay, मगर अगर हमने पूछा most common in multigravidas, then answer will change to complete breech. ठीक है, अगर हमने पूछा most common in multigravidas, then it is complete. Overall most common and in primies it is frank. Footling में क्या था, highest risk of cord prolapse. इसीलिए we were not doing ECV. What are we doing? A straight away cesarean section. Yes. So footling में we will do a straight away cesarean section. We will not do a external cephalic version. ठीक है. So these are different maneuvers that you should know for breech, right? And they can come as image based questions या फिर maybe indirect MCQs like external cephalic version. So with this we come to an end for today's session, and yes, I will share the PDF, but I hope कि आपको high yielding लगा हो. I have tried to discuss a lot of things which have high probability of being asked. I just hope कि आप सबका एग्जाम बहुत 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 अच्छा हो और आप खूब कॉन्फिडेंस से जाओ और आप हंसते हंसते बाहर आओ, एंड यू कम बैक एंड टेल अस मैम जीत के आए हैं. यस, सो अपना टाइम अपन खुद लाएगा. सो यू हैव टू गो विद ऑल द कॉन्फिडेंस, हैव फेथ इन गॉड, हैव फेथ इन ऑल द हार्ड वर्क दैट यू हैव डन, और मुझे लगता है कि आपकी मेहनत जरूर जरूर रंग लाएगी. जस्ट डरना नहीं है बिल्कुल, जैसे हमेशा कहते हैं डर के आगे जीत होता है, सो यू हैव टू टेक दैट लीप ऑफ फेथ, है ना। सो वो लीप ऑफ फेथ के साथ आगे बढ़ो कि ये एग्जाम इसीलिए बनाया है सो दैट वी रीच द नेक्स्ट फेज ऑफ आवर लाइफ, है ना। सो आप सब बहुत केपेबल हो, बहुत मेहनती हो, और मुझे पूरा यकीन है कि आप अच्छा कर आओगे। यस, और हम आएंगे, मैं और डॉक्टर सुमेर आपको ऑल द बेस्ट करने भी जरूर आएंगे। फिर दोबारा मिलेंगे, वी विल टॉक अबाउट सम टिप्स ऑल्सो दैट यू शुड टेक केयर। एंड टिल देन मैं बस यही कहूंगी कि मेरा बहुत सारा आशीर्वाद, प्यार आपके साथ है, और आपकी जीत में ही हमारी जीत है। तो हम तो जरूर चाहेंगे कि आप सब जीत कर आओ, राइट, और आप सब अपने नया फेज ऑफ लाइफ भी शुरू करो, ठीक है। सो थैंक यू सो मच कि आपने मुझे एक मौका दिया टू बी अ पार्ट ऑफ योर जर्नी, एंड इट इज ऑलवेज अ प्लेजर। आई होप कि मैं जस्टिस कर पाऊँ, एंड आप लोग भी मुझसे उतने ही प्राउड फील करो जितना मैं आपसे फील करती हूँ। यस, सो टेक केयर बच्चास, विजयी भाव जरूर जीत के आना है। God bless you all. Take care and we'll meet you soon. Lots of love. Bye bye. Thank you. And I'll share the PDF. Okay.